So if we'd like to stand and do the pledge, that would be good. I'll lead it. I pledge allegiance to the flag of the United States of America,
Alright, let's try in a bit.
for which it stands, one nation, under God,
Indivisible, with liberty and justice for all.
All right, thank you. This time, Victoria, you're on the call.
I am. Yes, I am.
If you would do a roll call for us, that would be great.
Sure. Mrs. Summers.
Hi, Victoria, here.
Hello. Thank you. Ms. Newman. Taub. I know you're here, Dr. Taub.
Oh, here.
Thank you. Mrs. Bernard.
Here.
Dr. Torres.
Here.
Dr. Guadalupe.
Here.
Ms. Root.
Here.
Ms. Namie Dyer.
Here.
Dr. Linda Meyer.
Here.
Dr. Hans. Mr. Furman.
Here.
Mr. Landsman.
Here.
Thank you.
All right. Thank you for doing the roll call. At this time, I'll entertain a motion. Well, let me ask first, are there any, from the board, are there any changes to the regular board agenda? Okay. If not, I'll entertain a motion for the approval of the agenda.
I move to approve the agenda.
Thank you, Adam. Is there a second?
I would second that. John Paul Torres, I would second the motion.
Thank you, John Paul. All those in favor say aye.
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 Any opposed? The motion carries. So we have approval of the agenda. Next item up is public comment. We welcome public comment. It helps us understand what's going on from the public, from those in the outside, to help us get some insight. So is there anyone on the list for public comment this evening?
Hi, Jonathan. No, there is no one online as far as public comment goes. We do like to remind people that there's a link on our website, or they can type a question in the chat and then a response will be given to them from our customer services team.
Okay, thank you. And also for those that are listening in or watching, there is a second opportunity at the end of this meeting. Okay. With that, I move on to the next item, which is the consent agenda. So I wondered if there's any changes to the consent agenda. If not, I will look for a motion for approval of the consent agenda.
It's Sarah Guadalupe. I will move to approve the consent agenda.
Thank you. Is there a second?
John Paul Torres, I'll second that.
Thank you. I think my notes say that we need to have a roll call for approval of the consent agenda. So if you wouldn't mind, Victoria.
Not at all. Mrs. Summers.
Yes.
Ms. Newman. Dr. Taubes.
Yes.
Mrs. Bernard.
Yes.
Mr. Torres.
Yes.
Dr. Guadalupe.
Yes.
Ms. Root.
Yes.
Ms. Namie Dyer.
Yes.
Mr. Lindemere.
Yes.
Dr. Hans. Mr. Furman.
Yes.
Mr. Landsman.
Yes.
Thank you.
Okay. Next item on the agenda, and I'm trying to follow this because I've got two different sets of notes. Are we looking through to approve the minutes of the various? I think so. Approving the minutes of the committee of the whole, acceptance of the CAC minutes, acceptance of, well, there is no oversight policy minutes, and acceptance of the recipient rights. So is there a motion to approve those minutes?
So
I'll
moved,
make that
Steve.
motion. Malchiah.
Thank you, Malchiah. Someone second it?
Second, Steve.
All right. Any discussion? All right, all those in approving of all of these meeting minutes, say aye.
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 Those opposed? Motion carries. Approval of all these minutes under the regular meeting agenda. Okay, so on to the next item on the agenda, which is our consent agenda that we've already approved. We have 2 items on there, which is the meeting minutes and the QAPIC. I think I want to take these. I've always not really understood the difference between consent and regular meetings, so I want to take these separately. Can we get approval of the OCHN board meeting minutes from 12/15? Is there a motion to approve those?
I'll make that motion. Malchiah.
Thank you, Malchiah. By the way, you're on camera. I like your hairstyle. Looks really nice.
Thank you. You're so
You're-
kind.
Is there a second?
Guadalupe will second.
Thank you. All those in favor of the board meeting minutes from December 15th, say aye.
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 Any opposed? Not hearing any, the motion to approve the board meeting minutes are approved. Okay, on to the FY21 QAPIC plan. Is there a presentation that goes with that, or do we, Marquita, are you planning? Is she on here, and are we planning to do a presentation on that, or just approve it?
I believe you had a presentation at your committee of the whole,
We did.
so then this would just be for approval.
Okay. Well, then I will be looking for approval of the fiscal year 21 QAPIC plan.
Motion to approve. This is Eric.
Thank you, Eric. Is there a second?
Second. Adam.
Adam, thank you. Any discussion? Okay. Hearing none, all those in favor, say aye.
Aye.
Any opposed? Okay, the motion to approve the fiscal year 21 QAPIC plan has been approved. Thank you. Okay, on to the agenda. So the first item on here is the Oversight Policy Board recognition. Dana, would you like to take this topic?
Sure. Good evening, everybody. I'm very happy to get this opportunity to honor this evening to celebrate Shelley Tobb as our chair of OCHN's Oversight Policy Board as she prepares to move on from this position. For those of you who are familiar with the Oversight Policy Board, it's our members are responsible for the governance and guidance of our substance use treatment and prevention services for Oakland County residents. Shelley's voice as an advocate and commitment to supporting our substance use service team has helped so many achieve recovery and lead the lives that they've dreamed to have for themselves and for their loved ones. And I can say, just being on a couple of meetings with Shelley, I can see her commitment and compassion about serving this community. Shelley, I know your award was sent to your home because of the pandemic, and I hope you'll keep it somewhere in view as a reminder of what you mean to our organization and the people you support. So I wanted to take into consideration your close relationship and working with Christina Nicholas. She's director of our substance use treatment and prevention team, and I wanted to give her an opportunity to say a few words about your partnership and your friendship you developed over the years as you work together on this board. So I'm going to turn it over to Christina Nichols. I hope she's here with us this evening just to say a few words.
Good evening. Can anyone hear me?
Yes.
Yeah.
Okay, great. I was having some technological issues earlier, so I wanted to double check. Well, good evening, everyone. I've had the pleasure of working with Shelley Tobb for a little over a decade when she was appointed to what was then the Substance Use Advisory Council for the Oakland County Coordinating Agency. She not only remained on the board during the transition from Oakland County to OCHN, but she was also very helpful and integral in creating the Oversight Policy Board. During her tenure, Shelley never missed a meeting. She always contributed with good questions and concerns, and she's been a tireless advocate for substance use prevention and treatment services, and most importantly, the people we serve. It's always been a priority for Shelley that Oakland County citizens receive the services they need in order to live happy and healthy lives. Shelley, I'd really just like to take this time to thank you so much from the bottom of my heart for your service to the Oversight Policy Board, for all that you've contributed and all that I do know you will continue to contribute in Oakland County in the future. Thank you so much. And with that, if you'd like to say a few words, we'd love to hear from you.
Well, first of all, I want to thank the Oakland County Human Services. I'm sorry, I'm a little bit nervous, not used to speaking on this thing. Oakland County Community Health Network and Dana for giving me this award along with the Oversight Policy Board. But I especially want to thank Christina Nicholas. I've seen her working not only here, but at the county when this was an agency of the county. And I've seen her working in Lansing and other places. I don't know if members of the OCHN board know, but you have a jewel. We are blessed to have Christina because I truly believe that she runs the best agency in the state without question. So I thank you all for this lovely award. I know that you can't quite see the writing on it, but it is beautiful and it will sit in my living room for a long, long time. However, I just want to let you know that you have a jewel in Christina and you have an incredible program. And it was my honor to serve, and it will be my honor to serve, I think, again. I'm not certain whether I can as a normal citizen, but this is quite an award and quite an honor to have. But mostly I'm honored to work with those of you working in mental health, as well as those obviously substance use. Thank you again very much. And by the way, you have it. I just want to say shout out to your team as well, Christina, because they too are incredible. I forgot one thing. I remember when you had to get rid of an agency. Sadly, they weren't complying contractually. And I know the amount of time you spent making sure that every client, every person you serve found a home when you dissolved this agency contract. That was so impressive. So again, I thank you. I thank Dana. I thank OCHN, which is what I call you, and the Policy Oversight Board for this honor. Thank you again.
Thank you so much, Shelley. And I couldn't agree with you more. Christina and her team are amazing. And it comes from us because we know and work with her every day, but it also comes from the state. So sometimes I don't like to say it too loudly. I don't want them to creep in and try to take the good folks away from us. But I know she is a gem, and as well as her team. And everybody is so committed. So we truly do appreciate your involvement and commitment. And I'm just sorry I didn't get a chance to work with you even more, because I have seen you in the meetings and how committed you are. So thank you so much again. And we're not able to replace you. So hopefully you'll find somebody very close that is committed as you are. Thank you again. So Jonathan, I guess we'll turn it back to you.
Thank you. And I just wanted to take a moment and say thank you to Shelley as well. You have been quite an energetic force, both at the county level and as part of OCHN. And I call it OCHN all the time. So I like that term. I think it's a way to go. But thank you. And thank you for taking me under your wing as well and helping me get acclimated to this board, as well as other things. So thank you for your years of service. I don't want to say decades. I'll just say years. Are you trying to say something, Shelley, or are you on mute? Okay, you are on mute. Okay. Now you're still on mute.
I think it's time for you to go on and go on with your meeting and for me to do something else, okay? So thank you for your kind words.
Observe and stay participating as a community member. How's that?
Thank you.
All right. Next item on the agenda is one of my favorite areas, which is stories that inspire. Tonight we have Don Flood from Student Leadership Services, along with the University Pediatrician Autism Center, so UPAC, if I'm allowed to say it like that as an acronym. So if you all wouldn't mind moving ahead with your presentation, that would be amazing. Thank you.
Emily and Michelle, are you online?
Yes, I'm on mute. Sorry, my computer's a little delayed. Would I be able to share my screen for the PowerPoint?
You know what, Emily, we have the PowerPoint embedded in this PowerPoint already, but you could introduce or share, introduce people that are going to give their stories of hope.
Of course. So, I'm Emily Wartella. I am the director of our Novi location of University Pediatricians Autism Center, which we do call UPAC all the time. And we do have a family who is going to be sharing their story with us all tonight, and her name is Tulu Cox. She has her daughter who has been receiving services here for just about a year now. Almost to the day, a year of her receiving services. So she will be sharing her story tonight. And did you want Tulu to go before or after our PowerPoint?
We would like her to go to first, if that's possible.
Of course.
Hi, good evening. I am Tulu Cox. I am the mother of Tia Cox. She's been receiving ABA care from UPAC since January of 2020. Tia was 4 years old when she started, and she's now 5 years old. We were given a list of providers from our care coordinator, Easter Seals, and after visiting and contacting most of the names that was on that list, we decided to go with UPAC was the best fit for Tia. Tia's life journey, around 2.5 years old, we noticed that there were some delays developmentally and motor skills. So we took her in to see her PCM, and she agreed that there were some delays, and she diagnosed her with ASD. From there, we were given information about a program called Early On, and that's where Tia started off with, was early on program. From there, we were led to ABA, which I've never heard of until having this experience with Tia. And with her insurance, we had to get a evaluation through Oakland County Health Department. They would approve the services if needed be. I would say her evaluation was around November of 2019 through the Oakland County, and Tia qualified for ABA services. So currently we are receiving ABA services through UPAC. Tia is going 5 days a week now. She started off the program, she was going 3 days a week. We were balancing off the Early On program and ABA. Let's see. She has progressed or improved so much since the first day she started a year ago. We see so much growth as she continues to go to ABA at UPAC. She started off with no vocals. Now she has. She started off with no eye contact. Now she makes eye contact. She started off with no communication skills at all. Now she has some. She also has growth in social skills to where Tia would not want to be around any other children or just people in general. And now she's okay with socializing, and she's even interacting with her siblings, mostly her sister, her older sister. She started off having no communication or comprehension of something. Like if we asked her to do something, there was no response. And through her ABA services, she is communicating and responding to direction of like we asked her to do something. There's no doubt in our minds that her progress and her improvements are because of the ABA care that she's receiving from UPAC. Our goal for Tia is to be independent and be able to take care of herself as she gets older and eventually when she's an adult. Our other main goal is for her to be able to communicate effectively and also be able to learn, continue to learn the receptive language and understanding. These are just a few of what we can think of for the moment, but in the end, as her parents, we just want her to be a happy child and be understood and just live her life fully. Again, like Tia is 5 years old, and she just started. ABA has been about a year now, but she's doing so well. We can't credit enough her team at UPAC. They work really well with her. She works really well with them. And we're just really excited about Tia's progress. And I like how the topic of what we're on right now for her presentation is stories of hope. And we do have hope that, Tia will continue to grow. And as she continues with her ABA services here at UPAC, there is hope that she just continues to make progress. We try our best to support her team in any way that we can. And at the end, we all have the same goal in mind, and that's Tia's growth. And so we're very appreciative for the services that we get there from UPAC. And that's it.
Thanks, Tulu. You have Heather crying over here. She's wiping her tears. So at UPAC, we do have 2 locations, both of which do accept Oakland County Medicaid clients. We have our Novi location and our Clinton Township location, and I do have our addresses listed a couple slides into this presentation. You can go, oh, there we go. So our mission at UPAC is to help improve the quality of life for children who have been diagnosed with autism and their families. And how we go about doing that is providing comprehensive and evidence-based treatment and assessments in order to help support our children or our clients and their families as best as we can. And then we also extend that knowledge to also providing other professionals in the field, whether they are nurse practitioners or residents going through the Wayne State program. We had a previous affiliation with Wayne State, so we had a lot of students coming over from Wayne State within different what's the word? Field houses, I guess, like speech pathology or occupational therapy, and they would come and kind of see what ABA was about. So just expanding the community's knowledge on what kind of services ABA can provide to children with autism. And then we also have done some work with some names out in ABA, such as Greg Hanley. So doing just basic and translational ASD research and helping to contribute to the field of ABA to make sure that we are keeping up to date and providing the most effective treatment that we can for our kiddos. And then our core values, which play into that as well, the compassion, integrity, innovation, respect, and accountability. Those are all things that we hold very near and dear to us, because without those things, we wouldn't be able to create the environment that we have for our families and really put a strong emphasis on providing safe and effective treatment for our kids that is effective. And also centered around the families and letting them allowing them to have their input into treatment, and then educating not only families but other professionals within the community. That is paramount for us to be able to coordinate with them, such as their physicians, the speech pathologists, especially the schools that all of our kids are eventually going to transition into. Those are all very important things that we are looking to do within UPAC. So something that makes us a little bit different is that we do have a multidisciplinary approach. We do have an autism evaluation center at our Novi location. So we do have coordination of care with the psychologist that does those evaluations, as well as with some of the neurologists over at Children's Hospital because of the AAEC, the Accredited Autism Evaluation Center. So we do have the opportunity to collaborate with the neurologists and the psychologists and the other medical professionals within the field in order to help us give the most comprehensive, well-rounded treatment for our clients. And then we also have very well-trained staff, and we very much pride ourselves on extra training that our staff members go through in addition to the base requirements that for behavior technicians that work one-on-one with the children. So this is some of our leadership and location information. So this is our address for our two locations. Our Novi we're right on the border between Novi and Northville. We're right by 8 Mile by Guernseys. And it's right off of the highway as well, off of 8 Mile. So it's fairly easy to get to. And then our Clinton Township location, these ones are, it's a little bit further out. So cities such as like Clarkston, or Waterford, or Lake Orion, those things within Oakland County might be a little bit closer to those Clinton Township locations. And then, like I said, I'm the director of our Novi location, and then Michelle Fiore is our director of the Clinton Township location. And then we have Mandy, who is our corporate project manager, and she is a good contact if we need to get anything, or what do you call it? I can't even think of the word. The contracts, I'm sorry, the contracts set up within any of the counties or with insurances or anything like that. So things that we work on at ABA, a lot of our big focus is on increasing functional communication skills, increasing language skills, whether that be conversations, if the children are up to that, increasing independence within daily living, reduction of problem behaviors, things that might prohibit them from learning within the least restrictive environment, particularly within the school settings and at home, working on social skills and play and leisure skills, getting them ready to be the most successful as they can within the school, early learning skills, and we do a lot of parent training as well. And then we also like to do a lot of coordination of care, like I've mentioned previously. I won't repeat myself, but doing the coordination of care with the other service providers, because as we know, that helps make the most well-rounded and comprehensive treatment for our clients. And again, within that, we do parent and staff trainings. It's been, through the pandemic, it has been a double-edged sword, I think you could say, as far as parent trainings go. But all in all, I think that it has been very beneficial with telehealth and all these Zoom and team meetings, because we've really gotten to take an inside look as to what goes on within the home, and then providing additional assistance and having the parents take those steps by themselves to make those strides with their children, but using those behavior analytic principles, and then seeing those big changes within the home that they've been trying to achieve. So that has been fabulous. And for example, Tulu, they worked on that a lot, and I know that bath time was a big project that they worked on over quarantine. And then again, we do extensive staff training protocols. We always try to offer as many learning opportunities as possible for our staff, because we know that as much training as they have and as much knowledge as they can have, then they can make decisions on the spot and independently, and have it be an effective treatment, an effective strategy to teach a child those skills that we're working on. So as far as services, we offer applied behavior analysis within our Novi and Clinton Township locations, and we also have autism evaluations within Novi. We have the ages that we serve are, the youngest that we typically get in is about 18 months. And up to 21 years. Usually for private insurance, they will go to about 18 or 19 years old for private insurance. And then I also listed our clinic hours on here for both of our locations. In Clinton Township, they are offering in-home services, and in Novi, we are going to be looking into doing in-home services soon. We are working out some kinks as far as our COVID-19 protocols and doing in-home services. So we're just trying to straighten some things out before we fully open up those services. Out of our total clients that we have 7 Oakland County clients, and that ebbs and flows from time to time as far as how many Oakland County clients that we have at a time. But we actually have one of our BCBAs, which is a board certified assistant behavior analyst. Her name is Heather. She is over here, social distanced with her mask. And she is one of our main providers for our Medicaid clients. And so she is the consultant for Miss Tia. So yeah, so there's that. And so at UPAC, our main goal is to provide safe, ethical, effective, and fun treatment for our kids. Of course, we have to be fun, because if it's not fun, they wouldn't want to come here. And then our behavior technicians, who are trained above and beyond what's required, which then enables them to deliver the most effective treatment. And I think all of our staff have a really great passion for working with our kids, and they show it on a day-to-day basis, which really helps the growth of our kids, and it's really great to see. So we're really proud of all of our clients and our staff at UPAC and all the progress that they've made throughout the year, even with a pandemic occurring. Does anyone have any questions? Oh, I see a hand raised.
It's me. I'm Judy Summers. Hi.
Hi.
I think I enjoyed the presentation very much, and I'm delighted that Tia's making such great progress. My question would be, is there a component to what you do that allows for families to also get together and support each other when you have young children who are faced with kind of unique challenges? Sometimes the voice of a person who's living the same life is really quite encouraging.
Yeah.
I know it was for me.
That's a really great question. So this isn't something that is currently occurring just because of parent interest has not been high within that, but we have previously done that within parent training groups where we would have groups of parents come in and we would kind of go over some behavior analytic principles, but then also give the parents a chance to share, I'm experiencing this at home, how are you handling that? And then that allows them to give some of that between it. But I think that that is an opportunity for us to grow as well, to offer some kind of services like that again as well.
I can tell you from having walked a similar road, not an identical one, that I'm still in touch with families that I met like 40 years ago. It's a lifelong connection and an amazing support system. So if there's a way to kind of encourage that, I think it might really be super helpful for your families along the way.
Yeah, absolutely. Thank you so much for bringing that up.
Well, thank you for your presentation.
Thank you, Judy. Are there other board members with questions or comments? Rena?
Yes, hi, Emily. I just wanted to say, mine's just a comment, just thank you for your presentation. This was very close to my heart because I actually am also a BCBA, and I own my own agency, and we actually work a lot with Wayne State and with UPAC. I actually have some graduate students from from Wayne State currently, and I have in the past as well. So I just wanted to say thank you for your presentation. It's really nice to see, you know, information from other agencies who are trying to do right by clients. You know, I know it's hard because I feel like in the state of Michigan, there's, as much as it seems like a lot of ABA agencies have kind of popped up and appeared, there's always still such a shortage, but quality care is something that is so important to this, especially with the intensity of the services. So it's nice to see quality care providers. So thank you.
Thank you so much. I definitely, I understand what you're saying.
Thank you. Melkaya.
Thank you, Jonathan. Thank you, Emily, and thank you to Tia's mom. I'm sorry I didn't catch her first name. I was listening to her talk about the progress that her daughter was making, and it just, being a person who has received services through the system, I can imagine how excited, not just excited, but amazed the family is once you've gone from challenges to seeing light at the end of the tunnel is just amazing. So I just want to congratulate you and your staff on the work that you're doing, and congratulate Tia on the progress that she's making, and just knowing that her life is going to be forever changed just from the work that you guys are doing with her. So thank you so much for your presentation.
Thank you.
Anyone else from the board? Okay. Emily, I just wanted to take a minute and thank you for your presentation. You know, over the last few years since autism came up and was covered under Medicaid, boy, what is it now, 4 years, 5 years now? Mm-hmm. Most of the talk had been about evaluations and very little had been talking about actual therapies, behavioral therapies, etc. So it's just, I'm glad that we had this on the agenda tonight, just so we could hear that side of the equation. So it's nice to hear. I really appreciate Tulo sharing her story with Tia in what they're going through. I know it's challenging, so it's good that there's a support system behind there to help them out. And I'm glad that we have a number of different very competent organizations like yours and arenas that can provide these services to the folks that we serve. So again, thank you so much.
Thank you for the opportunity. Appreciate it.
And thank you, Tulo, for sharing your story.
Thank you for the opportunity also to share. We're pretty new to the spectrum and the autism, but UPEC has been really supportive, and we're really happy to have them come alongside us and continue this journey wherever it takes us.
Well, thank you, guys. Can we move on to the next item on the agenda? And do we have something else from student leadership, or do we move on?
No,
with an
student leadership is in February. That I'm not sure if those are on your notes, but that's for in February, Jonathan.
Okay, well, it's showing on I have a printed copy of the agenda, that's why I wondered. So, okay, the next item on the agenda has to do with a COVID update through Honor Health. So thank you, Doctors Austin and Hamadi. It's good to see you, Dr. Hamadi, again, and Deb Brinson.
Yep. Thank you, Mr. Chair, Mr. Landsman, for having us today, for giving us this opportunity to present, giving you some updates regarding the COVID-19 vaccines. As you are well aware, there are 2 of them that currently have received emergency use authorization from the FDA. Before I get started, I also want to thank Dana Lassenby for giving us this opportunity. Thank you, Dana. Just to introduce our team today, of course, everybody has met Deb Brinson, our CEO. I believe she is on the line. And also Dr. Latoya Austin. Dr. Austin is the Associate CMO. I am the Chief Medical Officer here at Honor Community Health. So we're going to make a brief presentation regarding the vaccines. And following that, we'll leave a couple minutes for question and answers. I'm sure there will be some. So we want to make sure that we provide you with a very evidence-based update on the COVID status as well as vaccines. And again, opting in or opting out to get the COVID vaccine is truly based on the information that you have. And we want you to have the latest information and a very solid evidence-based information. So Dr. Austin, please go ahead.
Hello, everyone. I'm Dr. Austin. I will be discussing the COVID-19 vaccine with you guys today. The first slide just goes over a brief outline of what we'll be talking about today. I'll initially discuss the importance of the COVID-19 vaccine. I'll also go through both of the vaccines that are currently approved for use in the United States and their efficacy and safety. We'll go over some concerns, the goals of the COVID-19 vaccine. We'll discuss some future considerations as well as some take-home points. And at the end, we'll have a brief 5 minutes for questions. Okay, so this slide was done about 3 days ago. So the data we have is from about 3 days ago. So as of the 16th of January, as you can see, there was about 94 million cases worldwide with about 2,000 deaths. Here in the US, it was approximately 23 million cases so far, with about 395,000 deaths, which, as you guys know, is a huge pandemic happening right now. On average, we're averaging about 3,500 deaths per day. So this slide just kind of gives you an overview of what's happening in the last last month or so. To the far left, you could see we're testing about almost 2 million patients on average per day. And the second column goes over the average number of cases per day. We're looking at about 219,000 cases being diagnosed on a daily basis. To the far right, we're seeing that the average death for about a 7-day average is over 3,300, which is quite a lot. So the goal, this is basically showing you that, there is an ongoing pandemic happening right now, and it's really causing a lot of issues with our patients and our community. So the COVID vaccine was developed to hopefully try and reduce these numbers that we're currently seeing. So the first one that was approved was the Pfizer vaccine, and that received FDA advisory panel gave the approval for EUA authorization back last month in December of 2020. The second one was Moderna, and that also received EUA approval. The FDA panel did endorse the Moderna vaccine as well in December of 2020. So here in Michigan, we started vaccinating Group 1A with the COVID-19 vaccine approximately 5 weeks ago. And the Group 1A includes healthcare centers like Honor Community Health and FQHCs. It also includes hospital settings, health systems. Group 1A also includes long-term care facilities, and these were the first groups to have access to the vaccine. So this is a schematic outline of how Michigan plans to implement the vaccination schedule. So last month was the first time we were allowed to have the COVID-19 vaccine administered. So healthcare workers were the first group, as well as a long-term care facility. This month, we are also vaccinating healthcare workers as well as long-term care facility residents and staff. And just last week, Monday, I believe, Michigan started vaccinating our phase 1B group. This 1B group includes our schools, our childcare staff, and includes correctional officers, EMS staff, frontline workers, and also patients who were about 75 years older who are not covered in phase 1B. And so right now we are ongoing with the hope of increasing the rate of vaccination. Soon, once we have gone past the phase 1B, we will be entering into the phase 1C group, which includes patients under 64, under 65, or patients who are between 64 and 75 who have comorbidity conditions. So this is just an outline of what's happening across the states right now. To the far left, you see they have distributed approximately 31 million doses of the vaccine, of which approximately 12 million have been administered already. So the goal is to hopefully increase the rate of vaccination over the next few months. So today's goal is to help to educate you guys on the COVID-19 vaccine, and hopefully you can make your own informed decisions, and it will enable you to learn more about the vaccine and make a decision that's comfortable for you. So next, we'll be discussing the two vaccines and how the trials were developed and the safety and efficacy concerns. So there are two vaccines, vaccine A, which was made by Pfizer, and vaccine B, which was made by a company called Moderna. These are the first mRNA vaccines that were developed. They are not live vaccines, or not dead version of the COVID-19 virus, or not weakened COVID-19 strain. They're actually just a short portion of the genetic code for the COVID-19 virus. And what it does, the mRNA basically is a messenger that will help to produce the spike protein from the cells. And what it will do, it will teach our immune system to recognize the COVID-19 vaccine, COVID-19 virus, if in the future you are exposed to that virus. This is what it looks like. It's a big ball with these proteins on it. The red portion is the spike protein, and this is a part of the virus that the COVID vaccine was developed for. So I will briefly be discussing the Moderna vaccine. slide. So the Moderna vaccine was found to be about 94.1% effective. It is a 2-dose vaccine. You receive a booster 28 days later. The trial included approximately 30,000 individuals, of which the age group was from 18 and older. And it included individuals from different gender, different age groups, ethnic groups, as well as different race. So half of the group were divided, half received the vaccine and the other half received a placebo injection. Of the 30,000 people that received the Moderna vaccine, 196 subjects actually got the COVID-19 infection. And from that 196, 185 actually had received the placebo and 11 had received the vaccine. There were about 30 cases of severe COVID-19 infections, and all 30 came from the group that did not receive the vaccine, that was in the placebo group. So the Pfizer vaccine actually had very similar data. They had about 40,000 clients in their trial, and the data was very similar in terms of efficacy. If you look at the 95% effectivity of the vaccine itself, if we had a vaccine at the beginning of the pandemic, we would see that currently we have 23 million cases so far. And if we had a 5% rate of infection with the COVID-19 vaccine, you would see about 1.18 million people who would have had the COVID infection. And with a mortality rate of about 2%, you would see that we would have about 23,000 COVID-19 deaths if we had a vaccine at the beginning of the pandemic. Actually, today, as of 3 days ago, we had about 395,000 deaths from the COVID-19 infection. So had a vaccine been available prior to the pandemic really, moving, raging like it is now, we would have seen a huge impact on our death rates in the United States. So Moderna did meet all the FDA and EUA safety milestones. There are no serious safety concerns after the trials. They did look at adverse events, which are classified as grades 1, 2, and 3, which typically represents mild symptoms, moderate symptoms, or severe symptoms. They could be reported as localized, which would be at the site of the injection site, or it could be systemic, like a fever or fatigue. So in terms of localized effects, the most common side effects that people mentioned was pain at the site of the injection, as well as redness. Majority range from grades 1 or 2, 1 meaning mild, 2 means moderate. The average length, though, was about 2.6 days after the first dose and about 3.2 days after the second dose. And these occurred less than the localized effects. Now, in terms of the systemic side effect, symptoms such as fatigue or headaches or muscle aches or joint pains, those occurred, it lasted about 2.6 days, similar to the localized side effects. And the second dose, it was about 3.1 days. And as I was mentioning, that the systemic effects actually occurred much less than the localized side effects. Now, in terms of grade 3 adverse effects, it looks like it was, if you look at both groups, both the placebo and the vaccine, the group that received the vaccine, it was about 1.3% in the placebo group and 1.5% in the group that received the vaccine. But they are about the same, not significantly significant. And so the trial basically said that from a safety point of view, after looking at the data for approximately minimum of 2 months later, it was quite safe for the Moderna vaccine to be administered. So the side effects were milder and less frequent in older individuals, which were quite surprising because we thought that maybe the oldest subjects would have more frequent effects, but it actually was milder in the older population. In terms of concerns, so we've had patients who have discussed their concerns with us. I wanted to bring those to your attention as well. So some individuals are saying that the vaccine is the first time they've had mRNA vaccine. And in reality, it may be the first mRNA vaccine that was developed. But the concept of mRNA, using mRNA to make a protein is actually not new. This started back in the 1990s when they used mRNA and development of, to fight cancer and to fight HIV. And these studies, were much longer, and they've shown that it was safe to do over a longer period of time. So once again, this is the COVID virus. I wanted you to pay attention to the red part of the virus, which is the S protein that is called a spike protein. And so this slide, I would like for you to imprint this in your brains, okay? Because this is a part of where I would like for you to understand how the COVID vaccine works. So at the very top, you'll see the virus is injected into your muscle on the upper arm. Then the mRNA, which is the little squiggly line, enters your cell. Then in the cell, your ribosomes will make the protein, which is a spike protein. And if you look at where the mRNA is actually in the cytoplasm of the cell and is not in the nucleus, okay? Then once a protein is made, your body then produces different cells which can help you to fight that infection if in the future you're exposed. So this protein will help your cells to make you have your body to make two types of cell. One is called the T cell, one is called the B cell. And the B cell actually is what makes our antibodies. It's almost like a memory. So in the future, if you're exposed to COVID, you can then be able to block that virus from entering your cell. So that's what the antibodies do. The second cell that's made is actually the cytotoxic T cells. And what those do, if in fact your cells are infected with the COVID virus, your T cell will basically just kill that cell, so you wouldn't develop, an infection. So other concerns that we've been hearing is that the steps were skipped when they developed the vaccine. And I wanted to show you how vaccines are developed. So in the very top part of the slide, you'll see that is basically how vaccines are developed in terms of timeline. You'll see that we can sometimes have preclinical development of the vaccines. Then in the middle, you'll see where the clinical development typically happens, and this is done on humans, phase 1, 2, and 3. Phase 1 typically has about 100 volunteers. Phase 2 has about 1,000 volunteers, and phase 3 could have thousands of volunteers. And then once that's completed, then you do your large, scale production of the vaccine. In a raging pandemic, can you just go back one more? I wanted to focus on the bottom part of that slide. If you look at the bottom part of that slide, you'll see that phase 1 was initially completed, and then phase 2 and phase 3 were done at the same time. So the steps were not skipped, they were just done simultaneously. And the production of the vaccine was actually being done at the same time while the trials were going on. So the steps were not skipped, they were just done at the same time. And then once that was completed, then they went on to get the licensure for the vaccine. So as I mentioned, the speed of the vaccine development is a concern, and we understand that, but I just wanted to reassure you that the steps were not skipped in the development of the COVID-19 vaccine. Also, in the end of 2019, the beginning of 2020, we had the code for the COVID-19 virus was known for the spike protein, so that made it easier for them to develop the vaccine at a faster pace. Also, I'm not sure if you guys can recall, back in 2003, when we had the SARS outbreak, they actually had the concept of targeting a spike protein as far back as 2003. So it's not new that they were able to do that with this COVID-19 vaccine. mRNA also takes less prep time, so that helps with the speed of the development of the vaccine. And also, as I mentioned, multiple phases were done simultaneously in addition to the mass production. So the steps, were not skipped. I just wanted to make that very clear to you that, they were able to get the vaccine done at a time, in a shorter period of time, without skipping any steps. And the last concern was that because of the pandemic, they felt that they had to invest a large amounts of funds to get the vaccine, done well. We've been having questions being asked to us by our patients and our staff about, is a vaccine live? Am I getting injected with COVID-19? And as a matter of fact, you are not. You're getting injected with the mRNA, which then can make the spike protein, which allows you to make your own antibodies against it. So once again, this picture, I would like for you guys to think about this picture when someone asks you about the COVID-19 vaccine. As you can see, the virus is not injected, it is mRNA, and that enters our cells where the mRNA stays in the cytoplasm of the cell, which then makes the protein, which then elicits an immune response, and it's not in the nucleus of the cell. One of the concerns we've been hearing is that patients are asking us, could I be infected? Can I infect others because I got the COVID-19 vaccine? And it's less likely. So the goal is that once you're vaccinated, after your second dose, you will build enough immune response to develop enough immunity. So if you're exposed in the future, you will not get that infection. Also, in my experience here at work, we've been getting some concerns from certain ethnic groups that, the healthcare system in general, are a bit skeptical when it comes to taking care of minority patients and the vaccine in particular. But we wanted you to know that when it comes to the vaccine, if you look at who's affected the most with the vaccine, with the infection, we do know that certain minority groups have a higher mortality rate and are being hospitalized at a higher rate than other cultures. So the advisory group did put together the vaccine distribution that will mitigate all these health inequities, and hopefully will plan to distribute the vaccine across all groups so that no one will feel left out. So if you look at this group, you look at essential workers, they were first in line. That includes physicians or staff that works at nursing homes, long-term care facilities, or frontline workers. And so the goal with that, there's over 87 million people in that essential group that are actually non-healthcare, and that includes our minority groups. So they would actually be in that, 1B group that would be able to have access to the vaccine at a much, earlier rate than others in the population. So the goals of the COVID-19 vaccine is actually to help fizzle out the COVID-19 infection, and hopefully once enough people have been vaccinated, then we can hopefully, eliminate the COVID-19 infection. Herd immunity, I'm going to show you the next slide, which shows you what we're hoping to achieve with the COVID-19 vaccine. If you look on the slide to the left, you'll see the ones in the blue. You'll see those are individuals who have not been immunized and are healthy. And the ones in the red, those are the two individuals who actually have COVID and have not been immunized and are sick. And as you could see, if you look at the very bottom, you could see that they can easily infect, other healthy, non-immunized individuals. If you look to the extreme right of that slide, you'll see a group at the very top who are patients who have been immunized, who are healthy. But when they come in contact with someone who is in fact sick and with the COVID, as you can see, they will not get infected because now they're protected by having the COVID-19 infection. So as a whole, if enough people in the community have been immunized, you could see the rate of infection will decrease significantly over the course, over the course of the next year or two. And that's the goal of the COVID-19 vaccine. We can skip that slide.
Dr. Austin, perhaps in interest of time, perhaps we can skip over the next couple of slides.
Right.
And we can perhaps open it up to QA.
Are there some board members with questions? Yes, Dr. Hahn.
Thank you for the presentation. It was a very important overview of the vaccine. My question is this: if a person gets the vaccine, completes the course of vaccine, could they still be carrying the virus? Could they be carriers so that people who are not immunized could contact that?
Dr. Austin, I'll go ahead and take that question. So the answer is, so currently the CDC recommends that the period of isolation is for 10 days. Because what we have seen, based on the data that the CDC has given us, is that the virus loses its ability to replicate at about day 5 or day 6 after the infection sets in. So by day 10, majority of the individuals are non-infectious. There are certain exceptions to this rule. For example, those individuals who are critically ill have ended up in the ICU. We extend that isolation period to 21 days instead of 10 days. But again, those individuals are more likely to remain infectious for a longer period of time. But typically, by the end of about 21 days, the infectivity is almost zero. And that is one of the reasons why CDC changed its recommendation to perform nasal swabs prior to return to work. Because what they found was that several individuals stayed positive when you did a nasal swab for almost 3 months, but they did not have any virus in their nasal mucosa. What they did was they had little fragments of the virus, which were non-infectious. They could not produce disease. So that was the reason why the recommendation was changed. I hope that answers your question.
Yeah, thank you.
Mr. Torres?
Thank you. Just had to take myself off mute. It was extremely informative. I really appreciate all of the information, and particularly the herd immunity. You did a great job of explaining that, because I never really quite understood exactly what herd immunity was, so the diagram was very helpful. I read somewhere along the line that the flu epidemic in the early 1900s killed, I believe, 650,000 Americans. And I know we're edging towards 400,000 right now, or 395 as of the date of this presentation. Do you expect that we would surpass that at this point on the track that we're going, even though we do have a vaccine now?
I hope not.
Yeah, I hope not either. So, but I had a question about the efforts to get the information out, particularly to minority communities that have been particularly hurt by this. What kind of efforts are being done to reach out to the African American community and the Latino community as well?
So our job here is, we're educating our patients. We, as a committee, we're actually meeting, Dr. Hamadi's, we're meeting to decide how we will be educating, Pontiac's residents, whether it be in churches, whether it be in schools. So we are currently working on deciding how to let them know about it. Also, once we educate my patients, for example, like, I'm very big on education. I want them to know exactly, know about it. And so we've asked our staff as well to, we discuss it with them and have them educate their families and, and friends as well about it. So the goal is to have information sessions, soon. We will be hopefully getting the vaccines for our patients as well, so they can learn more about it prior to, getting the vaccines.
Mr. Torres, if I might add, I think I've practiced in this community for over 20 years. I think our community, I think people look for resources that are trustable. I think our patients look to individuals who they trust, where the information is transparent, and that it's delivered in a way that is understandable to our patients and to our community. So trust and transparency are extremely important They want to have a conversation and make an informed decision before they actually take the vaccine, opt in or opt out. And again, the message has to be delivered in a culturally and linguistically tailored manner. And that is very important. So.
And just one of the things I would add too, I know within the Latino community, you know, when I watch the Spanish channel, I see a lot of people have questions about getting the vaccine and if it could affect their immigration or there could be a problem with immigration. So just something to put in your guys' ear. Obviously, you know, there's a lot of great organizations like Hispanic Outreach and others in Oakland County that could help assist with that. But I see that as a hurdle within the Latino community that's occurring, you know, right now. But thank you so much.
Yeah. So, Mr. Torres, this is Debbie Brinson, the CEO. So we actually are doing a number of broadcasts next week with the Latino community on this. I think our big challenge right now is the amount of vaccine that's available, which is very, very limited. So nobody received a new shipment of vaccines this week. So we all have this large waiting list. And so there's this balancing act that we're doing between giving enough information, but not creating expectations that they'll get that vaccine right away or even relatively soon. So that's part of our challenge right now.
Excellent. Thank you.
I don't know if Jonathan didn't see my hand. This is Malkia. First and foremost, Dr. Austin and Dr. Hamadi and Deb, thank you for the presentation. This is really difficult. It's really difficult. There has been so much misinformation given out early on. And I'm talking to so many people that are just panicked. They're panicked about it. I had to pray. I had to talk to God myself. I've decided to take the vaccine. I had a Zoom call with my family yesterday, not yesterday, but Sunday. And most of them are dead set against it. And even it makes it hard for me to even say I'm going to take it, but I am going to take it. The opportunity was presented to me the very day I was asked if I could come in to take the vaccine. I found out that my 85-year-old mother, my sister, my brother-in-law, and my niece all tested positive. I found it out that same day. So that did it for me. I said, I'm going to take the vaccine. And I know that it's not going to be popular in my community. It's not going to be popular in my church. I've told my pastor that I'm doing this. But it's emotions are running so high around this. And all we can do is try to, what you're doing, remain calm and give people good, solid information and have trustworthy people alongside you. Dr. Reed has been a rock. I've been talking to her. She had the vaccine. She told me she was going to get it and I could ask her any questions. And she was very upbeat, very positive, very glad that she took it. But there is just so much fear and so much resistance because, and I was one of those ones, you know, we are used to being last in everything, an afterthought. So now when everybody is running to us to come and take this, it's scary. It's like, well, why are you coming to me now? You know, you never used to think about us. Why are you coming to us now? But again, the herd immunity helps to explain all of that. But this is challenging and it's difficult and it's scary. But I'm going to take it, and I want to do what I can to help. You know, once I take the shot, I'll be able to tell people, you know, my own personal experience, which I'm very good at doing. But I just have to say, it's people that are absolutely terrified to get COVID and terrified to get the vaccine. And if, I guess I'm just trying to say, just be gentle with people because we're afraid. Yeah. We're very afraid. Thank you.
Thank you, Melchiah. Dr. Guadalupe.
Thank you. Thank you both for your very informative presentation. It's come to my attention in the community, particularly with families of children who have Down syndrome, that they're concerned about the children because they potentially have a comorbid diagnosis, let's say diabetes. And so we know that at this time there isn't a vaccine available for those 18 and below, is my understanding, or 20 something for one of the other ones. So some of these parents are saying, you know, they're caregivers and they're not able to get the vaccine yet because they don't fall into one of these groups yet. Direct care workers or others who are kind of providing that same service are able to. So I guess my question is twofold in that, do you know of a way to try and advocate for these parents so that they can get that vaccine to help keep their children safe? And is there any news, or do you think there's any movement for the vaccine for children under the age of 18? And I think maybe one of them was 26. I couldn't remember the ages on those.
So Sarah, this is Debbie, the CEO. I think Dr. Austin or Dr. Hamadi can address what's happening in terms of the vaccine related to children and adolescents. And then they can talk also a little bit about the CDC recommendations. And then I can do a quick update on what's happening locally on that.
Thank you.
Dr. Austin, you want to talk a little bit about the trials with adolescents and children, or Dr. Hamadi?
Sure. So Sarah, there are trials that are currently being conducted by Pfizer in adolescents. And the same thing, Moderna has not specifically said anything about the trials. Pfizer's vaccine has been approved up to 16. Moderna is 18 and up, Pfizer 16 and up. You're absolutely right. I mean, I think one of the ideal ways to approach this would have been to create sort of a herd immunity around that around that individual who is susceptible. Unfortunately, there is no current guidance from the CDC as to how we should approach that. But ideally, it would have been to create that barrier, that herd immunity around that child who still can't get that vaccine because they're not eligible to, because they've not been studied. But to protect the adults, and therefore you protect the child, that would have been ideal. Unfortunately, we don't have any additional information on that from the CDC yet. Hopefully that'll come soon.
And so,
I'm sorry, go ahead.
Sarah, I just was going to say, I think the biggest challenge right now in the advocacy is to get the doses in. As long as there's limited doses available, CDC and local government hospitals have to make a decision about where those resources go. And given the amount that we saw, many sick people, many people, healthcare professionals who are treating COVID. If you think back to just 3-4 months ago, we had people just leaving mass and getting sick in the hospitals treating COVID. So I understand where they're coming from, but part of this right now is there's just no vaccine. And so hopefully with over the next month, we'll see some of those vaccines be able to be distributed out more widely. And then that net gets even wider in servicing. So for example, Honor has been open the entire time during this time period, seeing patients with COVID, without COVID, making sure people had their medications, working with your core partners on that. We needed to make sure that our staff stayed healthy, and sadly, some of our staff did get COVID and go out, and it just, you implode in at that point because you are running on a very skeletal crew, and yet this was the crew that was making diagnosis, sending treatments, keeping people on their medication. So I do understand it, but really, right now we need to be advocating to get as much vaccine as we can distributed.
Thank you.
Yep.
Ms. Root.
Hi, good evening, everyone. I first want to address Malkaya and just say that I'm so sorry for how this has all impacted you and your family personally, and I want to thank you for being vulnerable to share that with us. And I'm encouraged by your faith as well. And then I want to say thank you to Honor Community Health for this presentation. This was super informative, and thank you, John Paul, for bringing up the Latinx community. So I want to say that I recently started working with a nonprofit in Pontiac. It's called the Multicultural Family Center, or Centro Multicultural La Familia. And I just want to offer to Debbie or the doctors at Honor Community Health that once we reach the point where there are enough vaccines available, please connect with us, because we would love to share information to our clients and connect with them personally, so that way we can help address their concerns in Spanish, because most of our staff are bilingual, and we can get education to them and help connect them to the health centers that are offering vaccines. So I don't know, Debbie, maybe I could send you my email in the chat if that would be helpful.
That would be great, Christina. We've been working very closely. We actually are doing a number of broadcasts with them next week.
Oh,
and
wonderful.
Merlin Pera is on our board from La Familia. So we work really closely with Sonia as well. So I'd love, Christina, to add you to our team's list so that they have another person to reach out to. And then don't hesitate to reach out to us anytime either, because you may see things that we're just not seeing, and that would be real helpful for us.
Sure. Thank you. Thank you so much. And then my last point was just a suggestion. I didn't catch anything in this presentation about concerns that young women have who haven't started families yet. I know I've heard many women in my life bring this up, and then I'm also a young woman who hasn't started a family yet. So even though I plan on getting the vaccine for sure, that's still something that I would like to learn a little bit more about and see the research as it comes out, hopefully. But other than that, thank you so much for this.
You're welcome.
Unfortunately, Christina, we don't have any research data as yet on the pregnant patients or preconception patients, because the trial did not include pregnant patients, but ACOG did recommend, it says, do not withhold it from our patients who are considering having children in the future. So just want to give that to you right now.
Yes.
And we'll have more information as the data comes through.
Yes, thank you.
Thank you, Ms. Root. Mr. Lindemeyer.
Hello, thanks. I've got, I guess, two questions. One is, could you talk a little bit about other vaccines that are on the horizon? I think there's 2 or 3 others that are going to be applying for approval soon. And I signed up on the Oakland County government's website to kind of get in line for whenever my demographic comes up so that I can get the vaccine. Are there other opportunities to like register so that you can find out when you're going to be eligible and when you can actually get the vaccine?
So we can answer that multi-part. Deb, go ahead and answer the first part, if you would, please.
So right now, in terms of you did the great thing by going on to the county and putting your name in, and they will notify you as soon as they get enough vaccines. They're going to open up 5 centers throughout county and be open 7 days a week, 12 hours a day. So once they get those vaccines, I think you're going to see this movement really quickly. St. Joe's is also doing vaccines, but only for 75 and older, 65 and older. And they're doing a reservation. We're the other group that has it, and right now we're focusing on our core partners, our patients, schools, where our school-based health centers are. but we are getting a very small number. So I think once it opens up and we start getting more in and we have a good plan and we're consistent, we'll work with CMH and we'll do a clinic because you're one of our core partners. But until we get more vaccines coming in consistently, we can't do that. So keep your name on the county list because they by far are getting the most vaccines into the county and will continue to be the primary distributor of those vaccines.
So related to the vaccine, there is the, can you hear me? Hello? Yeah.
Yep.
There's the Johnson & Johnson vaccine. Data should be coming out very soon. We're hoping as early as next week. Following that, we anticipate that the FDA will review it sometime in the month of February. By the 3rd or the 4th week of February, we're hoping that we'll receive an emergency use authorization for the Johnson & Johnson vaccine. The biggest advantage of this vaccine is twofold. Number one is that it is a single dose vaccine. And secondly, it can be stored at refrigerator temperatures. So huge advantage. It's going to be a true game changer when this vaccine comes out. Again, the preliminary data suggests that at the end of 1 month, 90% of the vaccine recipients had antibodies. At the end of 60 days or 2 months, 100% of the recipients had antibodies developed. Again, very good data, at least preliminary data. We'll have to look to see what the FDA's advisory committee tells us about. They'll be, looking at the data in detail. So stay tuned.
Thank you. Are there any other board members with questions? I still see lots of hands up, but. Okay.
Hi,
Go ahead.
This is Bijaya. I went on the Oakland County website and I looked at their dashboard. It was about a week ago. There was like their doses that they had were able to administer were about 42% of what they had. I couldn't understand, was there a logistic problem or are there any barriers to establishing these clinics? My second question is that I had heard that we were thinking of having a site in our OCHN building, a clinic there for vaccination. Will there be any barriers to establishing a setup there?
So Dr. perhaps I can answer the first part. I think there is also a lag between the time that the vaccine is administered to the time that the data actually gets input to the data making itself to the Oakland County's website or the web page. So I think that could be part of that delay where you were seeing 42%. That's all I can really say in terms of the low numbers there. As far as the vaccine, Deb, would you like to comment, or anybody else from OCHN perhaps?
This is Dana Lassenby, and I just want to say there has been some discussion, and Deb and I actually talked about some of that last week when we spoke. And at this time, because of the supply issues, we're not able to plan anything formal, but that is the hope in the future that we could sponsor and support our own COVID vaccine clinic on site. So we know the challenges, and so we can't really plan and promise anything at this point, but that is our hope, to make sure that people have access to the vaccine through us.
I understand that. My question was not so much about the when, but or how, but it was that I understand that for the patients there is a waiting period of about 15 minutes or so where they have to be observed for anaphylaxis. In the event there is a severe reaction to the vaccine, will we be able to take care of those people? That was what I was thinking about.
So Dr. perhaps I can quickly talk about our experience in the 214 doses that we administered in the first round. We had 0 anaphylaxis. The recommendation is to observe for 15 minutes. That is a standard protocol. 30 minutes for individuals who have had a previous anaphylactic reaction. Majority of the reactions during that initial period are usually a little bit of lightheadedness. We had 3 individuals out of the 214 that experienced that. EpiPens are readily available. We have them by each individual's side, just in case we have to administer them. That would be the standard protocol for management of any anaphylactic or life-threatening reaction. Data from Pfizer that was published very recently, as early as last week, shows that 21 individuals developed an anaphylactic reaction out of all of the vaccines that they administered in the month of December. You know, a majority of those these side effects occurred within 13 minutes of administration of the vaccine. There were about 17% that occurred within about 20 minutes after administration of the vaccine. So very manageable by administration. There were no deaths related to the data that was released by the CDC either in that group.
Thank you.
Ms. Summers. Judy.
Thank you. This is probably a little bit in response to Sarah's comment, but I do know that the CDC has issued a guideline indicating that people with Down syndrome are to be considered higher risk, and that there also may be higher risk for reaction, but that I just wondered at Honor, do you keep on top of those? I'm sure you do. I don't doubt it, but the CDC guidelines, because I do know that I have a number of friends who have adults, you know, offspring, kids, family members with Down syndrome, and they're very concerned. They're in the, you know, over 20 up to about age 50 group, and they aren't in the age groups that are being identified, but they are identified by the CDC as being at high risk and should be prioritized that way. So it doesn't help for kids, but at this point in time, it is supposed to be available for adults with Down syndrome.
Yes.
Thank you.
Thank you.
I know we've been gone on this topic for over an hour, but I did want to say, as many of you know, I lost my mother over the summer to COVID down in Florida. My wife works at a hospital at Providence. She's gotten both of her shots, and not a big deal the first time. The second shot, you know, a little bit of flu-like discomfort, but that lasted less than 12 hours. I'm on the Oakland County waiting list. I'm over 65 now, officially after last week, but I will have to wait for my turn. I don't have any, I'm not at risk other than I'm quarantining at home here for 11 months now. But I want to thank you guys. I appreciate you guys working with a large portion of the populations that we serve. Continue to do that, frontline, essential workers. So Drs. Austin, Dr. Ahmadi, thank you so much for your help on this. I'm looking forward to either being able to get it from Ascension or from Honor or from Oakland County when they have it. I'm waiting to hear how they hope to actually reach out to those of us that have registered at the county level. And I know once they get a decent amount of supply, I'm sure they will be able to communicate what that expectation is. So again, thank you guys for coming out here tonight and for your
Thank you for having us.
Thank you.
Okay.
All right. Next on the item on the agenda is the November 2020 financials. Our CFO, Anya.
Good evening, everybody. Just to verify you can hear me before I get started.
Yes.
Jonathan, you're saying yes. This is going to be exceptionally boring after that very interesting presentation on all things science. So I have financials for November. If you can go ahead and switch to the next slide. This is the eligibility trend that you guys see every month that has, unfortunately, in a pandemic, gone up quite a bit, which is fortunate for us from a revenue perspective. So we've seen increased revenue. If you look at November specifically there, the reason that one is so high is because we received the first quarter payment of the direct care wage $2 enhancement. So that's why that one is up so much. But I do want to just draw your attention to the line that was from last fiscal year. So that blue line kind of demonstrates where we were this time last year, and you can really see starting in March is where that started to pick up. So that eligibility trend has really helped us from a revenue perspective, and will continue at least for the period that those individuals remain Medicaid eligible. So you can go to the next slide, please. So this, again, is looking at eligibles on a monthly basis, gives you a little better understanding of the population that these individuals are in. You can see the majority of them are Healthy Michigan and or TANF, which is Temporary Assistance for Needy Families. And the smaller amount being DAB, which is Disabled, Aged, and Blind, which is actually primarily where we get our funding from. So it's kind of an inverse relationship in that regard. Next slide, please. Okay, so this slide compares September of 2020, which would be the end of fiscal year 20, to the current month, which would be November of 2020. So it's only a couple months apart, but as you can see, our cash and investments has gone up slightly, not a ton. Our receivables have gone up, other assets have gone up, and capital assets have gone down just slightly, but not by much. But again, this is really just comparing a few months difference. So we wouldn't expect to see tremendous amounts of change. Next slide, please. So this is our liabilities, comparing the same time period. So September 30th of 2020 compared to now, you can see our liabilities in vendor payments are down significantly. That just fluctuates related to timing of when we cut checks and things like that. Due to state is not much off from that time period. Employee payables and long-term debt, again, not terribly different, but when you're comparing only a couple months difference, we wouldn't expect to see it tremendously different. Next slide, please. So net position, this one again is comparing September 30th. So you can see we are in good shape compared to this time a couple months ago by about a little under 4 million. Total liabilities is down, so our net position is up. So that's always a good thing. Next slide, please. So this particular slide compares revenue last year at this time. So it would be November of 2019 compared to November of 2020. So what you can see is the significant increase in revenue. Now remember, we did get that payment for the direct care wage enhancement in this particular month, so that's why it's quite a bit different. But on top of that, all those other things are coming into play when you look at that Medicaid revenue. Not only is the eligibility trend starting to come into play in this November, but also the adjustment in rates that we saw in the beginning of fiscal year 20 also came into play when you're looking at fiscal year 19 in November versus fiscal year 20. State general fund is exactly the same. County fund remains the same, and then all other is roughly the same as well. Next slide, please. Again, this one compares expenses from that year-over-year time period. So you can see administration is down. That's really more related to the adjustment in how we book a few things, not that it's materially different. Provider network expenses appear to be down. What we have looked at, because that one surprised me a little bit when I saw that on financials, we looked at the reality of that one is that a lot of expenses right now are going out in a cost reimbursed methodology as opposed to some of the other funding methods that we have. So then that gives it a little bit of a lag time. So you compile that on top of the holiday and the fact that we're in the middle of a pandemic, there's a bit of lag. So I do expect that to pick up a bit. But I think it's really just a kind of a catch up with everything going on. There's a bit of a lag in things being processed. Grants are down a little bit, not terribly, and then all other is not materially different either from year over year. Next slide, please. So net position again, year over year, you can see our net position. Total revenue is up quite a bit. Total expenses are down. So we have a net income about 18.4 million. So all is well this year compared to last year. Next slide, please. So again, this is the top 15 providers. That's very difficult to read. I apologize. That is in your packet, so hopefully you can read it or better on that one. But this is just what it pulls as the highest payments through the, November. So it grabs each of those as we've discussed before. Next slide, please. And this again speaks to those specific providers as it does every month. That should be it. Does anyone have any questions?
So this is Hadass. I have a question. I don't know if you can hear me.
Yep.
Yes.
Okay, great. Okay, I know we talked about it before, and then we made the request too that the top 15 providers list. And first of all, thank you, Anya, so much for going through this. It's very helpful. But that it's not the top 15 providers. It's just what's been paid. I guess either it's a little confusing to me. It's either what's been paid in the month of November. Is that what it is?
Yes. So it's the top 15 basically highest provider payments in November. So that's going to fluctuate. You're going to see a standard group of them, but then some of the other ones that are a little smaller, being with vocational providers and those types of things are going to fluctuate just really based on billings that month or when they were processed. So it will change.
Right. So the request is, and this is what we talked about last time, is that could you then tell us who they are? Like there's one that says BCA of Detroit. And I guess I have a question too of this. So my understanding that's a hospital in Detroit. So I don't know how that works and I guess that's a question I also have. So I have two questions. So the first is request, which I made last time, was that when they're not a top 15 provider and they're just the highest for the month, could you please define who they are? So I know that might take some time, but if it's only going to be 3 or 4 that are different, just add it on so we know who they are. So for example, I don't know who BCA of Detroit really is. And then, I think it's a hospital. And I guess my next question is, so do patients, from Oakland County, we pay them to go to hospitals out of the county? So I guess it's a request and then a question.
So a couple things. So would it be sufficient, the slide that is after the one that shows the payment amounts should be being updated to give you some information on each provider that is on that list. Whether that so it should. If not, we can make sure that happens. But would that meet your needs from identifying the provider?
Yeah.
Okay. And then secondly, BCA, yes, is an out-of-county hospital. It just depends on the situation. If we weren't able to get a hospital in Oakland County, yes, sometimes we do send people out of Oakland County, or if there's a particular circumstance. So it would just depend on the particular situation. And maybe that one was someone that had been there for a little while, and that's why they popped onto that list, because we paid their claims for however many days they were there, because hospital claims aren't paid until discharge. So if someone was there for, let's say, 15 to 30 days, you wouldn't actually see that expense on our financials until that hospital was paid.
Okay. And then I guess, and this is just in general, how many other hospitals besides BCA of Detroit, or agencies? I'm just curious. I guess maybe this is another question for a different time. Does Oakland County have as providers?
Yes, I think
maybe that's something to get back to me
it's either 11 or 14. And Dr. Lawson, I'm sorry to put you on the spot, but I actually think you know this number. If she's on, I don't know that.
I don't need to know them now, but I think it would be, valuable for us to know what providers we're working with outside of the county, and you can just maybe let us. I would guess the other board members might be interested in knowing too.
Okay, we'll circle back to that.
Okay, thank you.
Thank you. I see 3 hands up, one for Dr. Guadalupe, one for Ms. Summers, and one for Dr. Hans. Are all 3 of you in line ready to ask questions?
Sarah, I forgot to put my hand down from before. Sorry.
I figured so. Mine isn't near as exciting.
Okay. I'm going to go with Dr. Hans.
Yes, from my personal experience, to answer Hadass's question, a lot of times what happens is the patient comes to the ER and we're waiting for a bed and there is no bed available in the county. So they may have to go to the nearest possible, or logistically whatever worked best for the family. So this is not unusual. And now I don't know if OCHN has contract with each of the hospitals that have these beds available or not? That is something probably Nicole can answer.
So I do want to just add that Dr. Lawson just messaged me and said that the director of our service provider network, Jillian Trumbull, will have the list of providers, hospital providers, in her quarterly update. So it'll be included in that.
And it sounds like that might be a pretty interesting conversation that would be more informal than our normal standard presentations that are pretty dry during the business operations part of the committee of the whole meeting. Ms. Summers.
Hi, I just wanted Anya to find out what the timeline might be for presenting the pilot regarding the $15 an hour increase for wages for direct support professionals.
So we're just starting to circle back around to that after the holiday and everything. We're starting to talk about some of that stuff. So we will be sure and get that on either someone's quarterly update or make sure to get that information in front of the board as soon as possible. Quite honestly, we haven't circled back to it just yet, but I know we have some meetings scheduled and some thoughts jotted down for what that will look like.
Okay, thanks. I was hoping I wouldn't miss it, but I might. But I'm very
Well, you can always tune in.
In my spare time, I will. Thank you.
Are there any other questions for Anya? All right. Thank you very much for presenting this month's financials, actually November's financials. One day we will get to being able to present current month. Well, prior.
Don't hold your breath, Jonathan. That might not happen. We're not that fast.
I know. Next topic on here is our fiscal year 20 annual rights report, presented by Vicki Suter and Jean Fender. So please.
Thank you, Mr. Landsman. So this is our annual report. Just as a reminder, I'm Vicki Suter, the Director of Rights and Advocacy. The Rights and Advocacy Department is made up of two teams. One is the recipient rights team. Jean Fettner is the manager. And then also we have customer service, and Mike Daly is the manager of that. So between our teams, we assist people in navigating the system, solve problems for them, certainly investigate rights complaints and a number of other things. So this is the report that we are required to send into the state each year. I did give the board members a copy of the actual report. It's, number heavy. So our presentation is to try to make some of those numbers a little bit more understandable. And we are required to present this to the board. Next slide. So some of our complaint data information from the report. This shows the number of allegations that we received throughout the fiscal year 20. Also, how many of those allegations were investigated, and then of those investigated, how many were substantiated. So about 83% of our allegations were investigated. 41% of those investigated were substantiated. So the ones that were not investigated were items that fall into no right involved sort of category, and so it's not in our jurisdiction to investigate those types of things. So next slide. And this just gives you a 5-year span to look at the number of allegations and the substantiating violations to say, are we on track? Are we around the same of what we've been over the last number of years? And we are. So we're right around the average, so to speak, just below it, but not a significant difference in fiscal year 20. Next slide. And then just to do some data comparisons, so you have a sense about what does our substantiation rate really mean compared to the state. And so you'll see the 5-year trend there again. The last couple years, it's been around 40%, and that is not inconsistent with what the overall state average is regarding substantiation rate for allegations. So we're kind of in line with what is occurring around the state. Next slide. And then this is a complaint source. So this indicates where did the complaint come from, who made the complaint. And so again, this is taking data from the report. And in our PowerPoint presentation, I do put the page number of the report where you could find all of the data related to this particular graph. And so, you know, not unusual, a good percent, about a third of our allegations, complaints are opened by the ORR department. And oftentimes that comes through our incident reports, or we might get something from somebody might make a complaint, but they don't want to be the complainant. And so then we become the complainant. And then we also have about 21% from persons served who are the complainant, 14 guardians or family, and then staff of our provider network is 23%. There's not a really significant change over the previous year on our complaint source. It's very kind of typical of where it usually comes in at. Next slide. And this one I'm going to turn over to Jean.
All right. Happy to be here, everybody. Thank you for having us to present. This has to do with our time frames. And as you all may know, we have 90 days to complete an investigation. And this table simply shows where we are with how many investigations total versus being done within 30, 60, 90, or over 90 days. And, you know, we strive very quick to try to get this done very quickly. Can I have the next slide, please? One of the things that we decided to do a couple of years ago was to try and get our average days for completing investigations done, because first of all, we don't want individuals who are served to have to wait for outcomes of investigations or wait too long. And also for our provider network, sometimes staff are reassigned, put on administrative leave, or something like that while investigation is going on. And so we started off 2 years ago trying to bring those numbers, those average numbers down. Last year, we achieved our goal from bringing it down from to below 75. And then this year is pretty comparable. All right, so last year 59.9 days, this 0.09, and this year 59.9. So we're doing a really good job of trying to get those investigation lengths down day by day, week by week. Next slide, please. Okay, so basically individuals certain individuals are allowed to appeal. This is our appeals information. The appeals committee is made up of Recipient Rights Advisory Committee members. And we, in fiscal year 20, had 5 appeals, which is comparable to the previous year, where we also had 5. The appeals committee decides whether or not it's an appealable reason. And they decided that there's 3 reasons in 4 of those cases, which went to full appeal. And they upheld 3 and sent 1 back. All right. So overall, they 1 back for reappeal. So overall, they went through four cases, all right, which is pretty comparable, like I said, to previous years. Next slide. All right, remediations. In our annual report, we are required to report categories. And a remediation is something that a provider has to submit to us if there is a substantiated report, all right? And the remediation has to meet 2 criteria. One is it takes care of the incident that just happened, and 2, it prevents that same incident or similar incidents from happening in the future, all right? So this is a duplicate count. And as you can see, these are the things that our provider network have returned to us. And we have written reprimands, training, employee leaving the company versus employee termination, and others are some of our highest categories. Now, we always have at least 1 remediation. Sometimes we have 3 or 4, depending on what the provider sends back to us. Can I have the next slide, please? So this is remediation by the individual served, and providers that serve them. So obviously we have our highest number of investigations are done regarding individuals with intellectual disabilities. And so we have a much higher rate of remediations being done related to that population. And then you can see the other two populations, which are pretty comparable to previous year. So if I could have the next slide. So this is remediation by provider type. The vast majority of our investigations are done within residential services, particularly within specialized residential, where care is and support is provided, 24 hours a day, 7 days a week. So we expect there to be a lot more activity than, for example, in a program that only operates for a few hours, or that someone only participates in for a few hours a week. All right. So obviously, once again, going back to our previous data, we have residential providers are pretty high. So if you look at residential for individuals with mental illness, people with intellectual disabilities, combined homes, other side of the chart, SIPs, all of these different residential types make up for the majority of our remedial actions that are taking place. So next one. I'll turn it back over to Vicki so she can talk about training.
So thanks, Jean. And so training, we have to report on our training. All staff that work within the public mental health system have to receive new hire rights training within 30 days of hire, and we're responsible for presenting that. So much of this data is related to that. We were doing that training in person. It's about a 4-hour training. Obviously, with the COVID, we have gone to total virtual for most of 2020. So you can see that we have trained almost 5,400 individuals related to, on the computer. We also require that staff working within the public mental health system in Oakland County get a refresher rights course once a year, and that's an online course. So additionally, we've got people doing just computer. So the computer and face-to-face, that's probably the new hire. The computer is the annual update. And we also go out and do specific trainings to folks that we serve that live in residential settings. And you can see we had an opportunity to reach out to 561 of those. We're really proud of that effort. We really think that's important. And so in total, we trained about 8,400 people. Next slide. And then we have to report on our outcomes that we had established for fiscal year 20. We planned and provided a rights conference. We did accomplish that. It did have to be virtual in 2020, unfortunately. We also brainstormed ways to bring more awareness to persons that we serve who have mental illness. There was some concern that maybe folks with mental illness did not file complaints at as high a rate as people with a developmental disability, and what might be those reasons. So we did implement one of those ideas, and so that was accomplished. And then also we wanted to educate guardians about the rights of persons served. We accomplished part of that effort. We're still working on that. We got some of the things done ready to do that. And then with COVID, we had to kind of put things on a hiatus for that for a little bit. Early this year, we will be sending out letters to guardians of individuals that we support and ask them to attend one of our new hire rights training so that they have a really clear understanding about what the rights are of the person that they're a guardian over. So we're still working on that, and we hope to accomplish that hopefully early this year. Next slide. And then we had to develop outcomes for fiscal year 21. We did that in conjunction with our RAC committee. And one is to educate the community about the rights system, also for our members to obtain education on guardianship and supported decision making, so they have a better understanding about that and able to influence that within their sphere of influence. And then we want to provide training to our RAC members on important issues impacting the folks that we serve. So they want to become more knowledgeable in a variety of areas. Next slide. And then we also have to provide recommendations. These are same as last year. We would like the board and our executive director to provide the necessary support to the rights office, the board to review periodic reports and recommendations, and then also for us to have an opportunity to provide rights related topics to the board. to keep them informed and educated. Next slide. And now we're open to any questions you might have.
Mr. Lindemeyer.
Hi, I would just like to ask if we could have our data looked at and studied, the demographics, so that we can make sure and verify that there's no institutional bias based on demographics in any of the investigations, complaints, or the results. I think it's important to report to the community that we don't have any institutional bias.
And could you be a little bit more specific about what you mean by that?
Yeah, I'd like to know that if we have 10%, if our population served was 10% of the population was of one race, but that race happened to make 90% of the claims of the rights violations, I think that that's important for us to know. When we do investigations, I would like to know when there are investigations that one particular demographic is not being believed or not believed. And I think that in a lot of cases, there are unintended institutional biases that happen that we don't even realize. And until we look at it, we don't know whether it's happening or not happening. I don't know that it's happening or not happening, but I know if we're not looking at the demographic numbers, we don't know whether it's happening or not happening. And there are a lot of cases in our community recently where we see an awful lot of institutional bias that's causing people a lot of grief.
Okay, thank you.
Other questions? All right, I actually have one then. I noticed on one of the pages were sources of complaints, and 14% came from family members or guardians. And I wondered, given that there may be incidents or complaints about guardians or others that are outside our jurisdiction, because guardians, we don't compensate them, so I don't think they fall within our jurisdiction. How do we report those or resolve those?
Right, so we have to respond to any complaint that we get. And so if someone is complaining that their guardian isn't doing what they're supposed to do, we will send them a letter and let them know that we received their complaint, but it's not our jurisdiction in order to be able to investigate, and that where they could go to complain about their guardian, what could they do? What is the proper process for them to do that?
So in that case, that would be to the courts?
Correct.
Thank you. Mm-hmm. Any other questions for Vicki or Jean?
Right. This is Hadass. I have a comment and a question. Of course, my computer just froze. First, I want to thank you so much. It's a really, really helpful report. You guys do so much work in recipients' rights and taking care of everybody. So thank you, and thank you for putting this together. So my computer didn't, I think it was like on around page 111 or 112. I just didn't understand something on the report that it has, like, you investigated so many, but then it has 2 for intervention.
Oh,
and
sure.
I didn't understand what the 2 meant.
Yep. So intervention is something different than investigation. We do have the opportunity that if all the facts align and everybody agrees with the facts, we can do a process called intervention. It still requires all the same information in the investigation and in the report, but it's a shorter. We usually can get those done within 30 days or less, and it's because everybody agrees that it happened and how it happened, and it's not a complicated case, and it's not abuse or neglect. We don't do a lot of those because it doesn't typically happen. A lot of times we need to interview a number of people to really figure out exactly what occurred. So thanks for asking. But yeah, interventions are something that we can do. We just don't have situations that those fit into very often.
Okay, great.
And the inverse is true when you take actions as well. Sometimes one action can fix a few different problems.
Correct.
Correct? So
yes,
that's why the numbers never really match incidents and remediations.
Correct. Correct.
That's what I didn't understand either.
Yeah.
How come they didn't add together? Oh, I see. All right.
Yes.
Well, thank you again.
You're most welcome.
All right. Any other questions? Thank you, guys. I know you do a lot to do these throughout the year, keep them under 90. That's always the goal. And I know you have a rush to always get this filed in December. So thank you.
Thank you.
Jonathan?
Yes.
For some reason, I was unable to raise my hand, so I had to log off and log back in. But I just wanted to say that OCHN has basically a year-long training on supported decision making that I'm really looking forward to participating in. So, and I think that continues to be a great opportunity to discuss alternatives to guardianship. So again, just really looking forward to that training series.
Great.
Yeah, me too.
Other questions or comments? And welcome back, Adam.
Thank you.
All right. Next item is other business. And Dana, the floor is yours.
I think the other business, I'm sorry, and it doesn't appear that Sheila actually put it on the agenda, but it had to do with the Open Meetings Act and the updated memo provided by Kalana Ali. And so I'm not sure if the board members received that memo or not. I know Sheila had a personal family emergency, so I'm not sure if it was uploaded so that you could review it. So if possible, I'd like to defer that item to the next meeting.
Then we shall.
Thank you.
I wasn't sure if you were also going to introduce our in-house legal.
Oh, I thought I already had, but if she is on the line, I do believe she is. And if she's able to turn on her camera and microphone, then we can introduce her formally again.
Hello.
Uh-oh. So this is Kalana Ali. She's our new Chief Legal Officer. She started, I believe, is right after Thanksgiving, and she's been a wonderful resource, great support, great addition to our chief team. She hit the ground running, and so she's already viewed many contracts as well as our contract with the state, MDHHS contract for PIHP and CMHSP, as well as some other things that we had going on. So now she's looking at a number of other things so we can just continue to improve our practices. And then we'll have recommendations. Kalana's working on a series of recommendations that we'll share with the board, I believe, in the next month about how we move forward on some critical items. Kalana, did you want to add anything?
No, Mrs. Lassenby, I think you covered it pretty well there. Again, excited to report to the board starting next month on some items and going forward. So there was a productive meeting that was had. And if there are any questions regarding the Open Meetings Act, certainly can answer those as well. And I know that as things arise that we are implementing some policies on how to make contact. So.
Right. In general, board members, if you have a question that you want to, or you're looking for advice, you want to run it by or through our in-house attorney, through Kalana, I would say shoot me an email, copy or CC Dana as well. That'll get it to her. And then the response will come back either individually or overall to the full board.
Okay. And the other thing is working on the board bylaws. And so that is something that Kalana and Jonathan and I spoke of, and how we would move forward to support the board in reviewing and revising the board's bylaws.
but by having it in-house, it does make it easier for us to seek counsel. So it's a little bit different than with the outside firm that we still have.
Yes.
But Dana and Kalana will manage that relationship, so we don't have to. Okay.
Yes. Thank you.
Thank you, guys. Anything else under other business? Not? Then we'll move on to board reports. Eric, do you have an oversight, SUD oversight report?
No, I don't.
All right, thank you. Recipient Rights Advisory Committee. Actually, I think this is John Paul.
Something that's been put together.
Yeah, thank you. I actually was not able to go to the Recipients' Rights Advisory Committee this month, so I will be giving a report next month.
All right, thank you. And for the Citizens Advisory Committee, Malkiah? Ms. Newman?
Thank you, Jonathan. Citizens Advisory Committee report for December 16, 2020. The meeting was called to order by the chair, Lois Schulman. Introductions were given and the roll was taken. The minutes from the November meeting were approved. Public comment was given. The director's report was given by Dana. She talked about all the activity that was taking place at the agency, especially as it pertains to COVID-19. She is very pleased with the reception that she's received since starting in her position at OCHN by the staff provider network as well as the community. A copy of her report was sent to all the CAC members. Dana is still concerned that not enough people in Oakland County know who we are and what we do. She's meeting with key elected officials in the county and reaching out to community leaders in an effort to strengthen our relationships and provide more information about the services provided by our network. She encouraged the members to reach out to her if they had any questions or concerns. Christine Burke gave an update from the Communications and Community Outreach Department. She was dressed in holiday garb, and she explained that it was the day that the staff was having their virtual holiday celebration. She hoped to win the ugly shirt contest. We were very impressed with her outfit and the decorations she displayed in her work area. So hopefully we'll find out at tomorrow's meeting whether or not Christine won. She should have. She was outstanding. She also gave an update on the distribution of the tablets to people who we serve, who needed them for telehealth visits with their providers. All the tablets were activated and distributed with a 1-year prepaid internet service included. Language accommodations were made to assist people with how to best utilize the tablets. Christine also shared about the extensive mailing campaigns that have been taking place over the past 2 years to notify people served and other stakeholders who may not have access to email. The communication team is also mapping out their activities for the year with some target populations marked for more outreach. Among them will be the faith-based community. Mail contacts are planned to introduce the faith leaders to OCHN and encourage them to sign up for our mailing list. The agency's business cards are also being updated to help people in the community to better know who we are and what we do. Also, a greater effort is being made this year to be more inclusive. The team is searching for print media and organizations that are more specific to the people that they serve from different cultural and ethnic groups. Targeting advertising is planned in these publications to help get the word out about our services. Information about mental health is also being distributed to area school districts at the start of school, as well as the change in semesters. Christine encouraged the CAC members to contact her with their ideas on any groups or organizations we, the members, feel need more information about OCHN. Next, Sherry Rushman gave an excellent presentation on hope for the holidays that included many great ideas on how to make the holidays more manageable and meaningful during this COVID-19 season we find ourselves in. Sherry also shared that she's been reaching out to different committee members she knows that are at home due to the stay-at-home orders to check in with them and make sure they're doing well. She also sends out articles from her newsletter to help brighten up people's day. Next, committee reports were given by members. I gave my board update, sharing the results of our board election. Chair, Mr. Landsman, Vice Chair, Dr. Guadalupe, and Secretary, Mr. Furman. Respectfully submitted, Malkia Newman, Board Liaison, Citizens Advisory Committee. Thank you.
There we go. I was trying to get it off mute. Thank you very much. Next item on the list is the director's report. So Dana.
Good evening, everybody, again, and thank you for this opportunity to update you on what's going on around OCHN, or OCHN, as the board likes to call it. Again, I wanted to focus on some of the things that I've been engaged in at the state level, but as well as talking about what we're doing at OCHN to continue with the board strategy, as well as highlight some of the goals and objectives that we'll focus on this year. The first thing I wanted to say is that in December's report, I actually highlighted many of our accomplishments that were achieved by OCHN throughout the year, and there were many. And then going forward, as we talk about our report this day, and then also going forward to answer any questions that board members have, I want to make sure that you're aware I will be taking the goals and objectives from our annual plan and our strategic plan and responding to those things in my report. So as I listened to some of the questions that came up earlier, I want to make sure that we answer the questions that you have and that we're responsive to what you need to see to make those decisions. So first, Hadass had asked about the cost reimbursement by providers and those top, I believe it was 15 or 12 providers at the time. We will look at that, Hadass, and we will actually develop a report that will show you the reimbursement rates for the providers and type of providers that are at the higher levels, but also the types of providers and the number of people that they're serving that will give us some indication of cost of care for the individuals we actually serve. So more of a utilization management, utilization review report. So as Anya focuses on the cost and reimbursement of our providers, we really want to also balance that with utilization report to talk about the people we serve, where they're being served, and the outcomes that they're having. And this also touches upon one of Dr. Hahn's comments about and how it's determined where someone would go if they need inpatient care, for example, or any other level of care that we are responsible for managing and providing in the community. So again, it's really important that we align these things and these plans and objectives along with our plan, but also even today as I attended the data outcomes conference hosted by CMHA, Alan Jensen, who's the director or deputy director of behavioral health and human services, actually highlighted some of the priorities that they are focused on for the coming year and probably even beyond as they look at system transformation, which you're really not quite talking about, but we know it's in the works. But a couple of things that he did focus on, and I was happy to hear that they do align with what we're doing, and that is one, expanding access to and service capacity in a timely and for quality behavioral health services. So they're really looking at when people approach us and request services or if they're in crisis, how quickly do we engage them in those services that they need? The other thing is increased family-centered or person-centered planning. And as Adam talked about, the training that's important about supportive decisions. We really want to support a lot of those things, but we want to also make sure when we're doing the training and we're starting with a baseline number of people who have received or engaged or have guardians, but after receiving the training and support, how many people actually decided that they did not need a guardian or they could manage and make their decisions for their own lives. So that's really important as we do look at training and look at the number of people that we're impacting, but we really want to come back to this board and show you outcomes. So that's another part of yes, increasing family-centered and person-centered planning, but what have been the outcomes when we train the community and talk to the families about what it is they need to look for and ask for and advocate for. So that's really important. The other thing that he talked about is increased collaboration with community stakeholders, with MDHHS, payers, and the provider system. And I think as you look at some of the things that we're bringing to the attention of this board, as we talk about stories that inspire hope, as well as hearing from Honor and how we're going to assist in making sure that people we serve get vaccines and have access to vaccines. We're doing that, but we need to report it and demonstrate it even more. The other things that he talked about had to do with reducing racial and ethnic health disparities. So there's a work group for that. And we also have our internal diversity, equity, and inclusion group that we're working with to ensure that we're also practicing what we're telling the community. And the final thing, and I think this is one of the things that we really should be proud of, is value-based purchasing and payment reform. So while they're talking about that at state level, when I came through the door back in August, there was already a payment model in place, a service model in place as to how we work with our provider network, and we pay them based on outcomes. So that's one of the things I'm really proud about. And I also can say there have been many occasions where people from the state contact us, and including when you look at some of the meetings we're going to, a lot of the chiefs and the other members of our team, like Christina and Jillian, they're really actively involved at those state level meetings. So it makes us look good, but it also is important because we are demonstrating to the community the value that we bring, and always putting people first. And finally, I do have some numbers that I wanted to report, but another side note is when I work with the other CIOs or CEOs, at the PHPs, there are 3 things that I have actually taken under my umbrella as I work with that group. And that includes reporting back from the Michigan Autism Council. And then also that group hasn't really worked well with the advocate groups. And that has been since February of last year. So that was one of the things that I volunteered to actually work with the advocate groups, and have already reached out to a couple of people and setting up meetings and hoping we can rebuild those relationships. And finally, really looking at our software tools, such as our medical necessity criteria tool, which is really our way to look at parity between the physical health and the behavioral health plans. So again, we continue to look at and make COVID a priority in terms of how we operate and support people. And looking at access is always at the top tier of my priorities, making sure people have access to our services and looking at ways to improve our crisis response, because those are also big things that are part of the state. So just to give you an update on the COVID numbers, in December, we reported we had 129 people who tested positive, and 17 of those people actually lived in specialized residential settings. So in January, as of January 14th, 16 people tested positive for COVID, 2 lived in specialized residential. So the numbers, we don't have a full report for January, but I'm hopeful that we will have access to the vaccines. I think the information that Dr. Hamadi and Dr. Austin shared is very critical, and we maintain that communication so that we can make sure there are no barriers for people that we serve and that are serving and working directly with people. Those are the essential workers, that they are also having access to vaccines. So we don't have a lot of data on that part of it yet, but it is something that we are focused on and working towards. It's making sure that we can get those reports to share with this board as well. So I'll end with that and open it up for any questions anyone may have. But it's really important to me, as I hear you ask questions, the board asks questions, that we incorporate responses in our upcoming reports. So I've heard that consistent throughout the time I've been here, and I want to make sure that we're responding and giving you the data that you're asking for. So thank you.
Thank you. Mr. Lindemeyer, you have a question?
No, my hand was up from before. I'm sorry.
It's all right. Ms. Newman.
Thank you, Dana, for your report. I just wanted to add to your list of things to bring back to the board, a review of the payment models. I know that we had to suspend doing the payment models during COVID, and we went back to them. But I can't remember when we've had an update on the payment models. I still don't fully understand them and would like to have a deeper dive concerning them and to know what the successes and the challenges are with that. Thank you.
You're welcome. And if I could add, I know Mr. Lindermeyer, you asked a question about the demographics as it relates to recipient rights. And that is something that we'll try to break down and get that information, because I agree with you. There could be some potential institutional bias. And if there is, we want to see what trends there are and look at opportunities to address it and improve what we're doing.
I think that something related to that is your focus and Christine Burke's on in terms of community outreach.
Absolutely.
From the same, maybe not the same, but from a similar perspective.
Mm-hmm.
There are populations being underserved demographically.
Yes.
All right, at this point, we are at public comment. Is there anyone?
Hi, Jonathan. We did not have any public comment this evening.
All right, thank you. I'm looking at the lateness of the hour, and I'm wondering if are there any board members that wish to provide public comment rather than just going through the list? Yes, Ms. Summers.
Thank you, Jonathan. I just want to wish Tia and her family continued success, and I hope they get the support they need to really move a good life forward. It's pretty exciting to me. The other thing I'm kind of wondering about is the 21-day challenge. And are we going to discuss that? Are we going to look at incorporating that into our policies or our approach going forward? And as always, I appreciate the effort that went into the presentations tonight. They were great, very informative, and I appreciate all of the effort that went into providing them. Thank you.
Thank you, Judy. Dr. Taub.
Yeah, just a couple of things. First of all, I'd like to add my congratulations to Shelley Taub for the award she got. And just being around her, I want you to know that she does a lot for the community, and it's nice to be recognized. Now, this is the second time that we've have a meeting scheduled that conflicted with a Michigan basketball game, so maybe we need to take a look at that in the future so that doesn't happen. More seriously, on the COVID vaccine, statewide, only about a third to a half of the doses that have been delivered have been actually given. And even though they were holding back for the second dose, but that's been lifted. And the larger counties like Oakland and Detroit Wayne are not proportionally being given enough doses. And actually the doses that we are allowed to have, we're not even getting those. There is no vaccine. I agree with what Jonathan did. Register at all the hospital systems if you can. I'm registered with Oakland County and with Beaumont and a couple others, but most of them won't even let you sign up with them because they don't have any vaccine. And when they do get it, they don't get what they're supposed to, so they can't be making appointments. Just maybe a private company or maybe our new president will get it better organized, because remember the 10 most feared words in the English language is I'm from the government and I'm here to help you. And they're not doing a good job getting this vaccine out. That's all I have.
Any other board members with wishing to make a comment? All right. If not, I wish everyone well. Just another reminder, there will not be a study session this month, so this is it for the month. Please stay well. Please get on the list. Cross our fingers that they call us. And thank you very much. Have a wonderful evening. Good night.
Thank
Good
you.
night, everybody. Be well, everyone.
Be well.
Be well.